speaker, Professor Dr. Ozcan Yıldız from MEDIPOL Mega University Hospitals. We're going to do his presentation about oncology medicine. Please, Professor, the floor is yours.
Thank you very much for inviting me for this prestigious meeting. Dear guests, dear colleagues. Today I chose a topic called precision medicine, which is very popular in medical world at the moment. And we are on the way of a personalized healthcare with precision medicine. Next slide, please. Next slide. Yeah, if we define precision medicine, we mean precision medicine is a way healthcare providers can you correct the cameras, please? Yes. Precision medicine is a way of healthcare providers can offer and plan specific care for their patients based on the person's genes or the genes in their cancer cells. Next slide. So precision medicine looks at how a specific gene change or gene mutation might affect a person's risk of getting a certain cancer, or if they already have cancer, how their genes or genes in their cancer cells might affect treatment. Next slide. So personalized medicine in cancer requires identification of genetic alterations that drive carcinogenesis and treatment with drugs that can effectively inhibit the function of genetic alterations. For example, a mutated gene in this pair has changed the DNA translation or RNA translation of the gene so that a cancer, a driving mutation can cause a cancer. Yes. So what is the current definition? Use of therapeutic agents that target any biological abnormality that is associated with carcinogenesis, including immunotherapy. So we want to hit the target with that gene if we produce a specific drug for that mutated gene. So mutations can be inherited from one or both parents. This is called germline mutations. So germline testing is gaining importance. For example, PARP inhibitors, if we detect germline mutation in the DNA, we can give PARP inhibitors to prostate cancer, pancreatic cancer, for example, breast cancer, or even prostate cancer. So we can divide mutations into two different forms. One is germline mutation, which is inherited in our normal bodies, normal cells in our body. And we have also somatic mutations, which is only present in our tumor cells. So what did that mean? So somatic mutation, for example, a normal lung cell can be mutated so that lung cancer cell can be produced. For example, a normal islet cell in our pancreatic cell, if there is a mutation in the cell of pancreas, a diabetic islet cell can be produced. So how genomic alterations cause cancer? When genes are altered or mutated, the resulting proteins produced can have altered sequence, structure, or function. Sometimes no protein or complete proteins are made, resulting in dysfunction in the pathways that regulate cells, growth, division, and death, for example, which causes cancer. So cancer is a dynamic phenomenon. It is caused by accumulation of genomic alterations. It starts with fertilized egg, continues with gestation, infancy, and then ultimately a lot of mutations accumulate. For example, if you, as you see, the red circles are somatic mutations, and the gray circles are the other mutations. So when they accumulate, a cancer can occur. So this is called genomic instability. So we have to understand all the genomic alterations. All cancers arise as a result of changes in the DNA of cancer cells, though not all of these changes present in a cancer would have been involved in its development. These are called passenger mutations. We have many, many passenger mutations. As you see in this slide, maybe 10,000 passenger mutations. But in one specific cancer, for example, in lung cancer, we see only 5 to 10 biologically relevant alterations. So these are called driver mutations that can cause the actual cancer. So one or two of the driver mutations can also be actionable, which means we can target this mutation with a specific drug so that we can treat the patient. Sometimes a cure can occur. So how do we test? How do we test all these mutations? We have different types of mutations, so we have to test all these mutations. For example, one is base substitution, the other is insertion and deletion mutations, and one is copy number alterations, and the other is rearrangement or gene fusions. So the genomic alterations driving the tumor growth is depicted in this diagram, in this slide. For example, in a base substitution in EGFR gene can cause an EGFR mutation, so a specific EGFR mutated lung cancer. For example, another one is EGFR lysine 858R mutation or L861Q mutation. So this is another type of lung tumor that we can target with a specific drug, which is now in the market. Or another one is BRAF mutation, which is also a very specific mutation that can be detected in with next generation sequencing methods. So this is another example, which is called an insertion and deletion mutations. For example, in EGFR exon 19 deletions in lung cancer is actionable. We can target this mutation with a specific drug called erlotinib and gefitinib. So sometimes we see copy number alterations. If there is a copy number alteration, for example, in breast cancer, which is called HER2 amplification, that we can test this with different methods, also with next generation sequencing methods. So we can give Herceptin to breast cancer. So this is called, literally, this is called a tailored medicine or precision medicine. So rearrangement mutation or gene fusions is another example. For example, RET fusions in lung cancer or thyroid cancer can be targeted with a very, very new drug, which is in the market very recently. So what is the key learnings up to now? Cancer is a disease of the genome and the result of the accumulation of genomic alteration over time. The 4 different classes of genomic alterations that I have just explained is associated with driving tumor growth are base substitutions, insertions and deletions, copy number alterations, and rearrangements. So you see here, we test all these mutations with different types of methods, methods. For example, immunohistochemistry, FISH, PCR, Sanger method, or NGS-based hotspot testing or hybrid capture, and finally, whole exome sequencing or whole genome sequencing methods. So NGS technologies have enabled comprehensive genomic profiling. So what is the advantage of this? So this can be done very quickly. For example, an NGS test result can have a turnaround time around 1 week or 2 weeks up to now, and which is quite cheap according to the previous ones. So are we ready to say goodbye to one-size-fits-all cancer treatments like chemotherapy or radiotherapy or hormones? So maybe yes, because precision oncology paradigm is shifting now our understanding of cancer treatments completely. So cancer cell we have a cancer cell. Even single cancer cell can be tested with genomic analysis, and we can have different variants like HER2, P53, MEK1, EGFR, or FGFR1. So we have many drugs specifically to these mutations. So precision medicine in cancer is being used for certain cancers that help now what tests and treatment are best, identify who might be at high risk for cancer. So patient A with mutation A can be treated with drug A. Patient B with mutation B can be treated with drug B. So doctors might use precision medicine to help them prevent some type of cancer, find certain cancers early, diagnose a specific type of cancer correctly, choose what treatment options are best, and evaluate how treatment is working. Incorporation of levels of evidence into variant reporting clinical practice. So in recent years, molecular profile is ordered as standard of care or for clinical trials. So we can direct our patients according to mutations to different kinds of clinical trials, which are run in Turkey, also in Europe, and also in Ukraine. I have seen in one report, you have running a lot of clinical trials in your country. Interpretation of molecular profile. So expert oncologists in precision medicine are required, specialized team of molecular biologists. So selection and treatment on clinical trials is based on recommendation of tumor molecular board, clinical trial availability, patient preference and eligibility, and study sponsor and insurance approval. So why now? Because the time is right, because sequencing of human genome is possible. Improved technologies for biomedical analysis like biostatistics or bioanalytics, new tools for using large data sets. This is called big data. So we can study this big tool with bioinformatics very quickly. So precision oncology has changed the survival of cancer patients. For example, once with chemotherapy, when the survival of metastatic breast cancer, it was around 12 months or 15 months. Now with chemotherapy plus trastuzumab, a smart drug, the survival now increased more than 2 years. Another example is Gleevec. For example, with chemotherapy, CML was a deadly disease. Now there is a Gleevec, which is a smart drug. Even cure is possible in chronic myelogenous leukemia. So what is the challenges in precision oncology? We have tumor heterogeneity. So when we sample one tumor from one site, maybe some mutations is not there. Maybe if we sample the tumor again, or if we sample another organ, another metastasis, the tumor the mutations can change. So we can hurdle these problems with now liquid biopsies. We can draw blood and we can see different kinds of mutations in the circulation, in the circulating DNA of the tumors, which is called cell-free DNA. So precision oncology, in spite of challenges, is very popular, very important, and I think this is the future of modern medicine, modern cancer treatment. So molecular profiling, prognostic markers, markers predictive of drug sensitivity and resistance can also be detected. So markers predictive of adverse events can also be detected with one report. So a typical precision oncology workflow is, in day one, when a patient visits a clinic, we take the biopsy in 2 to 4 days. Pathology review is up to 5 days. Sample preparation in the 6th day, and molecular analysis in 8th day. Bioinformatics, 9 or 12, 11 days. Molecular tumor board should be gathered in the 2nd week, and maybe in the 3rd week, results and treatment can start. So molecular tumor board consists of multi-institutional participants like medical oncologists, surgical oncologists, bioinformatician, pathologists, radiologists, radiation oncologists, and maybe geneticists. So we have different kinds of trials running at MEDIPOL at the moment, of course, in different areas of the world. So an umbrella trial is an important trial. In one type of cancer, we can detect different kinds of mutations, and we can test several drugs at the same time in the same trial. Another trial called basket trial, multiple types of cancer can be tested simultaneously if there is one common genetic mutation, and we can test one single drug. So if we broaden our ideas, for example, if we want to understand how all these precision medicine works, we have to analyze meta-analysis. So if we for example, if you look at this paper from Maria Schwarterle, yes, this is a phase 2 clinical trial. We see with precision medicine, yes, next slide, please. With precision medicine, with personalized medicine, if there is a pool analysis, a meta-analysis, you see the response rate is much higher than the conventional personalized medicine, if you see on the left-hand side. So in the middle, you'll see the median progression-free survival of cancers. If you treat the patient personalized medicine, you see much better than the not personalized one. And in the median overall survival on the right-hand side, you see a far better outcome with personalized medicine. So if you see the Kaplan-Meier curve, which is the survival curve, here, the traditional, the green one is worse than the red-colored curve, which is the targeted treatment. So overall survival is also far better than the standard chemotherapy. If you treat our patients with targeted cancer therapy, you see up to double survival. So we divide our results into different tiers, like tier 1, tier 2, tier 3, and tier 4. And so tier 1 is very of strong clinical significance. So we see a very good result, for example, if there is a drug and very good outcome, we say this is a tier 1. So tier 2 is variant of potential clinical significance. We treat our patients, maybe not FDA approved, but this is FDA approved with different types of cancer, but we can still treat the patient with that drug. So for example, lung cancer mutation, there are many different types of mutations in lung cancer, like KRAS, EGFR, and many rare mutations. But these mutations are very, very good mutations for patients. They can be targeted very easily with smart drugs, and we can have very good outcome. For example, this is a BRAF mutation in a patient with salivary cancer. You see here on the left-hand side, you see the cancer, which is in dark colored. The black ones are all cancer on the upper body. So after you treat with a drug, with a smart drug called demorafenib, the patient's all the lesions are vanished. So how can the cancer patient be tested? So this is called, for example, Foundation 1 CDX. This is a commercial test from Roche company. A solid tumor can be tested easily, as I explained in previous slides. All solid tumors can be tested. So there is a companion diagnostic indications, for example, for lung cancer, EGFR testing, or ALK testing or BRAF testing. They are all tested at the same time in a single test. So this is a sample test. For example, this is ordered by a physician. An EGFR mutation has been found, and we can treat this EGFR mutation with 4 different types of drugs called afatinib, gefitinib, osimertinib, or erlotinib. So we have to choose one of these drugs. These are all FDA-approved therapeutic options. We can also find different kinds of information from the same test. For example, if the patient has microsatellite unstable, we can choose another drug. Or if the tumor has a high mutation burden, we can choose another drug, which are all FDA approved. For example, this is a patient with high tumor mutational burden with 24 mutation per megabase. So we can choose different kinds of immunotherapies called atezolizumab, durvalumab, or pembrolizumab. So what is on the horizon? So comprehensive assessment of cancer is the future. So we test the patient with DNA sequencing. We can find epigenetic alterations. We can see microRNA expression, RNAs with RNA sequencing. And we can also do multiplex immunohistochemistry staining at the same time with the same sample without sacrificing our sample tissue. And finally, we can test the blood with circulating DNAs, and we can see our patient's outcome dynamically. For example, after the patient progresses on one drug, we can still test the patient in their blood with different kinds of genomic mutations. So I wanted to give you my select cases. For example, this patient was a 58-year-old man diagnosed with lung adenocarcinoma and liver metastasis. So conventional molecular investigations were all negative with the old methods. So after 2 cycles of cisplatin and gemcitabine, he refused further chemotherapy. So a PET-CT revealed brain, progressing bone, lymph nodes, and liver metastasis. So I ordered a comprehensive genomic screening with this patient. So we found different kinds of genomic alterations in this patient. For example, one is ROS1 fusion. So I could give this patient a smart drug called erlotinib or gefitinib. Here you see. So for ROS1 patient, I can give ceritinib or crizotinib to this patient. So this is the detailed explanation of why I can give this smart drug to that patient. Yes, we can skip. So this is another patient, a 37-year-old woman with triple negative breast cancer. Yes. So this patient also had TP53 mutation, which we don't any smart drug for that patient, but this TP53 mutation give us a very good idea about the prognosis of the patient. So how the patient progresses, how serious the patient has his tumor, her tumor. Yeah, this is the typical report of TP53. This is another patient, a 30-year-old woman with gastric mass and liver metastasis. Endoscopic biopsy was an adenocarcinoma. This patient actually had a biliary tract carcinoma. So this patient has EGFR amplification and ERB2 amplification. So I can give this patient, I could have given this patient different kinds of treatment, but I have given this patient trastuzumab because we detected ERB2 amplification. The patient responded well to cisplatin, capecitabine, and trastuzumab, which is a tailored drug a smart drug for precision medicine. So another patient, 58-year-old Turkish man with stage 3 left lung adenocancer, received chemoradiation between November 2017 and January 2018. He was a 30-pack-year current smoker when he developed bone metastasis and a new lesion in the contralateral lung. Pemetrexed, carboplatin, and bevacizumab combination was started. And we ordered Foundation 1 DCX test for this patient. And the patient had NF1 mutation, which is associated with a smart drug called, yes, trametinib or cobimetinib. So trametinib was an FDA-approved drug for this patient. And also the patient had high tumor mutational burden, which is associated with a very good drug called avelumab. Yes, we can skip all these. This is another woman called 65-year-old Libyan woman. Also, we had, in this patient, we had P10 abnormality. Yes, we can see the report. P10 abnormality, tumor mutation low, microsatellite instability stable. And the patient can be treated with everolimus and temsirolimus with P10 mutation. So another patient, a Libyan patient, 70-year-old. This patient had also lung cancer with metastatic. This patient also had NRAS mutation with trametinib. Trametinib was a smart drug for that patient. Yes, we can continue. Yeah, we can skip all these. Yeah, this 58-year-old non-smoker man presented with right-sided pleural effusion. When he was diagnosed with lung adenoid cancer from the effusion, we staged the patient as stage 4 lung cancer, and we requested Foundation 1 DCX test. So the patient had EGFR mutation, which I taught before. So we can give the patient osimertinib. So I gave this patient osimertinib for EGFR mutation. The patient's lung, if you see on the right with the arrow, a huge lung mass with pleural effusion. So after 2 months with a smart drug called anti-EGFR. Yes. After 2 months supply of osimertinib, the patient's mass disappeared, as you see in this slide. Thank you very much. So if you have questions, I am happy to answer your questions.
Yes, thank you, Professor Ozcan, for comprehensive and detailed presentation. We have actually 2 questions come from the audience saying that whether you have any experience of using a combination of chemotherapy with the new generation of the medicine, or you are not using it as a combine.
Yes, we can combine smart drugs, immunotherapies, especially we combine immunotherapy with chemotherapy for lung cancers, for different kinds of cancers. Yes, this is possible.
It's possible to
use
a combination, depend on the patient.
We have a lot of experience, and it's also FDA approved to combine it. We do it.
Good. The second question, Professor, also, can you combine 2 new medicine combination, the new generation?
Yes, we can.
Yes.
For example, we can combine a BRAF inhibitor with MEK inhibitor. We do it. So as far as they are tested in clinical trials, they are not toxic. As far as they are not toxic, we can easily combine. Because if there is one resistance to one drug, we can overcome that resistance with the other drug, like antibiotics.
The last question that you have shown one example, I think he was man, has metastasis in different part of the body.
Yes.
Specifically asking which medicine you have recommended for, particularly for this patient.
The very first slide was a BRAF inhibitor. No, this was an example from an internet. The last case was my case.
All right.
The last slides were all my cases.
All right.